Shall I use this? Hello, good afternoon. Hello, after that very inauspicious beginning, my name's Rebecca Marcus. I'm here on behalf of Linda Gale Becker, Deputy Director of the Desmond Tutu HIV Foundation and the President of the International AIDS Society. And I really hope it's going to be worth it now. I feel like the anticipation is vast. So I'll try and be as swift as I can. And after the speakers have spoken to us this afternoon about the past and the progress that we've made, I'm going to try and tackle the future of paediatric HIV. And just this reminder from Michelle Sidebe, the Executive Director of UNAIDS, who tells us that we cannot run away from the crisis in paediatric AIDS. We must ensure that 100% treatment coverage for all children living with HIV, and no child should die of an AIDS-related illness. And the great news is that there is newfound global momentum to reduce paediatric HIV infections and mortality globally. And as Sanjana mentioned, the UNAIDS global targets towards ending the AIDS epidemic, the 90-90-90 plan, says that 90% of those living with HIV should know their HIV status, that 90% of those living with HIV should be on sustained antiretroviral therapy, and that 90% of those should have durable viral suppression. So this global plan was launched at the turn of the millennium, and unfortunately we have fallen somewhat short in 2015 of its target, but we are actually well on its way to eliminating paediatric HIV if we keep the momentum of the global plan. Is that better? Okay. And we should also, is that better? Okay, sorry about that. We should also keep in mind that we're about to undergo a huge youth bulge in sub-Saharan Africa, with double the population of 15 to 24-year-olds today than we had at the start of the epidemic. There are already 30% more young women in South Africa than there were in 1990. And we're starting to see this in our treatment programs. Some data here from the AIDS conference in 2016 in Durban this year, which shows massive ballooning of treatment requirements of adolescents as they transition from childhood to adolescence through to adulthood. And this is the 2020 goal: eradication of pediatric infection and a reduction to less than 500,000, fewer than 500,000 new adult infections per year. And actually, the exciting thing is there is a lot to say about how we're going to get there. And I'm going to just touch on just a few in the few minutes that remain. Of course, we always need more information, more research. And there are many, many collaborations in South Africa, Sub-Saharan Africa, and worldwide that are focusing attention on the pediatric HIV epidemic. And one here is CIPHER, which is the flagship pediatric initiative of the International AIDS Society that promotes HIV research relevant to women and children and adolescents in resource-limited settings. And their aim is to have targeted research questions to optimize service delivery and clinical management to strengthen pediatric HIV cohort collaboration. And of course, as mentioned earlier, we know that we really want to retain our children, our patients and infants in care. And one of the big problems with a lot of the health service is that care is not joined up. And we lose people along every step of the way. And something that was alluded to earlier is the development of a rapid, accurate point-of-care assay for early infant diagnosis of HIV. Access to early infant diagnosis is limited in many settings, and as alluded to again earlier, PCR testing is expensive and is often restricted to laboratories. And there are many logistical steps between testing, return of results, return of the infant follow-up, linkage to care, and initiation of antiretrovirals. And at every step, there's the chance of attrition. And in South Africa, it's estimated that only 71% of PCR-positive infants do link to care. And many of those, there is a delay in initiating treatment. And we've heard from Prof. Cotton the importance of early ART initiation in infants. South Africa actually is doing better than a number of other countries. These data actually are worse in Cambodia, Botswana, and Senegal, for example. But it's very important that we can have perhaps a palliative care test, that we can start infants on antiretroviral therapy at diagnosis. And of course, we really need to look at improved ART regimens for everyone who looks after children and adolescents in care. We know that many of the drug regimens are not palatable. There are multiple tablets with multiple side effects. And this is the ARV market for pediatrics is fragmented and quite small. This is also a heavily treatment-experienced group, and we know that a lot of our children and adolescents are resistant to first-line therapy. The Drugs for Neglected Diseases initiative takes on a number of sort of neglected diseases such as filariasis, sleeping sickness, and so on. And they've taken on pediatric HIV under their mantle, and they're committed to developing and registering a fixed dose combination, so one tablet that a child can take that's palatable, that's easy to take, and we really hope that progress will help young people to adhere to treatment. Of course, it's important to mention the other comorbidities associated with HIV in South Africa, primarily TB, but in sub-Saharan Africa, we know there's a huge burden of malaria, pneumonia, diarrheal disease, and it's important that we join, we link care, we have better access to screening and treatment of comorbidities. And something that we're hearing a lot of discussion at the moment is how to actually prevent new HIV infections. And for this, we need a prevention revolution. And Prof. alluded to the revolution that we had in the past 20 to 30 years with HIV, and we really need another one now. And the ingredients are, of course, innovation, technology, political leadership, societal pressure, very important, and the resources. And we will not reach 90-90-90 with a business-as-usual response. The second ingredient, innovation, has mushroomed in the past 10 to 15 years. And we now have a vast array of innovations that we can use in primary prevention, and we are using in primary prevention at the moment. And a number of these prevention technologies are currently being tested or have been tested and will be tested in South Africa. I'll just talk about a few here. So pre-exposure prophylaxis refers to something that a person without HIV can take every day or can use in order to avoid HIV infection. And you may have seen from earlier this year some data on vaginal rings. We know that oral pre-exposure prophylaxis, that is a tablet you can take every day to avoid HIV infection, is and the data is well established. But we really need to get to a place where this is being implemented and this is available to all those at risk, particularly in South Africa, our key populations, which really includes adolescent girls and young women. The other thing that we are looking at with pre-exposure prophylaxis is a long-acting injectable. And this is what all young people, when we talk to them about oral PrEP, say, why can't we have an injection like we do for contraception? And actually, this is currently in development and currently being tested. You may also have heard yesterday about the HIV vaccine that was launched in South Africa yesterday between Cape Town, Johannesburg, and Durban. And at the moment, in infants and babies, there are infant and baby studies, but these are very relatively early phase clinical trials. I think it will take some time before we get to that place for young people, for babies and infants, I should say. And the importance of PrEP cannot be overemphasized. This kind of data shows that if there is anywhere you want to put primary prevention, it's into young people with a lifetime of potential HIV acquisition and transition ahead of them. And if we can prevent transmission during this vulnerable period, then we can really make excellent use of our prevention dollar. So it's very important now that we lever as much political support and societal pressure to enable young people to be able to access these really important prevention technologies. And I just wanted to share just a small amount of data from the first Southern African adolescent oral pre-exposure prophylaxis study we're doing in Cape Town, in Masiphumelele at one of our research sites, and also in Soweto and Johannesburg, where we've enrolled 150, 15 to 19 healthy HIV uninfected young people, both young men and women. And just a few things to tell you a little bit about this, just some early data, that a staggering 50% of young people at enrollment had an STI. And this is in a context where we have no testing for STI, and we know there's a strong biological link associated, an epidemiological link associated with STIs and HIV transmission and acquisition. So this is something we could be really focusing on. Essentially, the data show so far is not too dissimilar to some of the adult PrEP studies. So it shows us that young people are happy to have some kind of tool that they can own their own sexuality with. So instead of negotiating condoms that we've been asking young people to do for a long time, actually to have a pill that you can take, that you can control yourself to avoid HIV infection. And as yet, in this cohort, we've had no instant HIV infections. The other thing I think that is very important is to move away from some of the negative messaging that there has been around HIV acquisition. And we're looking now at things that are really going to appeal, particularly to our adolescent cohort and young people, and looking at what we call gain frame messaging. So really positive and really, as much as we can, empowering messages towards HIV prevention. And just the last thing really is to talk about HIV cure or remission, because I think everyone who looks after patients with HIV often has their patients saying, but when's the cure happening? And there's obviously been a much discussion about HIV cure and remission, and little is known about how to actually achieve it. And there's a debate over whether we will reach cure or rather remission of HIV. And the definition of cure is the complete eradication of all HIV-infected cells or the permanent absence of plasma viral rebound after ART discontinuation. And we only have one example, one patient anywhere in the world that we think we've achieved a cure, the Berlin patient, who you may have heard of. And when we talk about remission, we are talking about perhaps a functional cure, defined as where people living with HIV have stopped antiretroviral therapy and are able to maintain a low or undetectable viral load for an extended period of time without the adverse impact on health. And as Prof. Cotton talked about, the only case that we had a lot of hope for was the Mississippi baby, but as yet this still eludes us. So the last thing really to say is that scientists have developed this huge array of effective tools, which if implemented could reverse the AIDS epidemic. And this is from one of the scientists who first discovered the HIV virus. And there is certainly a lot of hope that this is the generation that can end HIV. Thank you.